Right here. Okay, so, okay, yeah. And then so for the camera to pick her up, she's going to have to stand over here, or do she prefers to stand? Oh, you prefer? Perfect. Yep. Okay. Okay, good evening and welcome to day 3 of the National Public Health Week. This has been a very exciting week for us. I'll get a little bit more detailed information. Public health is an exciting profession, and the first week of April is celebrated as National Public Health Week to showcase all the amazing things that we can do in public health. As you may have noticed on the screen, before we put up the speaker's notebook, we have 3 major events, plus a Stewie group had an event this afternoon. Monday, we had a speaker talking about the history of public health at New York Medical College. Tonight, we have the renowned Levine talking about issues in public health regarding family caregiving. And then tomorrow, we have kind of focused this on our high school students in the area, undergraduates, to come into roundtables and talk to professionals in public health to talk about why they got interested in public health. And as many of you know, public health is a discovery major. And so not too many high school kids think I'm going to go into public health. And this is an opportunity for them to let them know all the different things that we can do. There are a number of people I'd like to thank for this. Certainly, our Secretary Cindy Jakubowski has been instrumental in helping with things, along with our grad assistant, Ikea, as well as our former administrative assistant, Mariage Bruneman. She retired last week. But really, I think the key thing we have to acknowledge is that Jeffrey Patrick has done a lot of this, and Jeffrey's over there. He's going to introduce our speaker here in a few minutes, but Jeffrey done a great job. He's created sponsorship. We have one of the sponsors over here, Dr. Bruce Valori. He's a dentist and a founder of the Pro Health Dental. And we really appreciate the support, along with West MD's our other sponsor. So let's give Pro Health Dental. Jeffrey's done a lot of this organization, and he's worked hard and he's pulled all his hair out. I mean, that's how much work he's done. So, but I'm going to come back up here, but I first want to introduce our Dean, Robert Amler, the Dean of the School of Health Sciences and Practice. He wants to say a few words. I'm going to come back and just real quickly talk a little bit more, and then we'll introduce our speaker. So, Dean Amler.
Thank you very much. Thank you. And to be here with Carol Levine and the others is a real privilege. Happy National Public Health Week, everybody, if you haven't heard me say that. Isn't this just a marvelous space that we're in this evening? What a great open space. You don't see this too often in academia, and this is really great. I wish I had just a few extra minutes to show you the suite that's across the way. It is a simulation lab for training of dental students, dental residents, and instead of a Resusciani CPR doll, there is actually a head mannequin at each workstation into which you can insert a particular type of mouth of teeth, and then you can work on those teeth with real dental instruments, the real metal ones, not fake plastic ones, and the angles are just right. And since my dad was a dentist, I love to sneak in there and pretend that I could do this too. So it really is an amazing training site. It has a central stage where the instructor sits and by video can see what every single student is doing with their, practice dental work. And those of us, I think it's everybody in this room who enjoy good dental work, okay? Isn't it great that they get to practice on a dummy and I don't have to be the dummy? So that is just great. So welcome as well to the dental school. We're really glad to have you. The whole field of aging, elder care, elder law, and all of the issues that come around aging is such an amazing field with innovation and almost explosive technology. And I know you're looking forward to hearing about some of this evening and from the panel. I'm just going to say that we are so privileged to have Ms. Levine here, and thank you for being with us. And thank you also to the students who helped us put this week together, and in particular, Mr. Jeffrey Patrick, who is going to take the honor of doing your introduction. So everybody, let's enjoy a great evening, and thank you all very much for coming tonight. Thank you.
Thank you, Dean Ambler. As he mentioned, do want to thank the the College of Dentistry at Toro, I think that's their title, for allowing us to use the space. It's pretty nice. Okay, here's what we're going to do. I'm going to introduce Jeffrey. He's going to then introduce our speaker. We're going to have a speaker, depending upon how long she wants to talk, 3-4 hours, whatever it might be. We'll take a short break afterwards, and then we'll reconvene with our panel. And then we'll have a chance to have interaction with the panel. They can respond to some of the issues that Ms. Levine has talked about. We have plenty of food. We now have plenty of water. So help yourself. And when you do take that 5-minute break, let's plan for 5 minutes so we can get to the panel at this point. So as I mentioned, Jeffrey Patrick's really been the one organizing. I've worked with a lot of graduate students, doctorate and masters. I don't know if I've met a more passionate person and a person who can get work done. The fact that he got sponsorships is pretty impressive. So we're thinking of not even allowing him to graduate so that we can keep him for a couple of years. So I'd like to introduce Jeffrey Patrick. Jeffrey, thanks for your help.
Good evening, everyone. Okay, so first of all, I would like to introduce myself. My name is Jeffrey Omar Patrick, for those of you who do not know me. And second, Dr. Valori, I want to thank ProHealth Dental for putting forward the effort and really helping us get this thing on the road, okay? Definitely. And of course, WestMed Medical Group also was one of our sponsorship, okay? So we're running a little late, so I'm not going to take long to introduce Ms. Carol. Ms. Carol and I have been sending emails back and forth to each other. A little love relationship kind of blossomed. But Ms. Carol is an expert on. A matter of fact, if you reach underneath your chair and if you find a sticky that says "I love NYMC," you're going to get her latest book, Navigating Your Later Years. And so if you reach under your seat and if you feel a sticky, you know what? I thought some of y'all were going to be sitting over there, so there might be some stickies over there. But you should, if you find a sticky to say "I love NYMC," you're going to actually get one of her book, and you can have her sign it. Miss Levine is an expert on speaking. Oh, there's plenty more in here because I put them all around. So, oh, you got two. Okay, so he can share. Ms. Levine is an expert speaker on the topic of aging in a society, and she's going to enlighten us today, and she's going to be as didactic as she possibly can and letting us know how the aging and the caregiver is one and the same. The caregiver lacks a little care, okay? And she's here to tell us why this is a public health priority and how we can actually help to accentuate this type of topic. So Ms. Levine, I'm not gonna hold it up much longer. I could go through all your awards, but I figured we're gonna get her on the mic and get the show on the road, okay? Give her a hand for me, pretty please. You got the.
Thank you, Jeffrey.
No problem.
It's great to meet you after all.
Yes.
I forgot. Okay. Okay, that should be better. Better? Okay. And it's great to be celebrating Public Health Week here with you. And it's actually great that I'm here because it was a long ride from mid-Manhattan. I think the subtitle of my talk is important, from invisibility to a public health priority. And I'm going to try to explain why that is happening and what it means for our society. Now, I work at the United Hospital Fund in New York City, which is a nonprofit independent health services research organization. We don't really deal directly with hospitals, although we certainly have colleagues in hospitals, but we look at health policy across the spectrum of care. And I direct the Families in Healthcare Project at the United Hospital Fund. And we have a website called Next Step in Care, which is intended for family caregivers to explain how to navigate the healthcare system, particularly in times of transition. Okay, so what I'm going to try to do tonight is this overview is show you why family caregiving, and I'll explain what I mean by that, but it's been seen as a personal, not a public health or public policy issue. It's just something that families do, and we don't look at it too closely, and we certainly don't support it very much. But today, in today's society, family caregiving is very complex and it's very challenging. As some of you may know, you may already have had experiences or know about experiences in your own family. So what is happening, as you all know, changing demographics and aging society, chronic illnesses, and healthcare system changes make family caregiving a public health priority. I'm also going to talk about some regulations that really are intended to support patients and caregivers, but follow that somehow inevitable law of unintended consequences. They don't do exactly what they were intended to do. And then a little bit about future needs. Okay. Where's my tech person? Am I doing something wrong already? Sorry, I'm pressing it. Oh, yeah, I pressed the button. Okay. All right. I did a little research on word clouds, public health. Say, where does caregiving fit into the word clouds that are public health? And you've seen all of these. All of these are probably things you study and know about or teach. Where's family caregiving? It's not there. There's some little bit of up in the corner there. It says social support, but that's basically it, and it's very tiny, and it isn't really very descriptive of all of the things that family caregivers do. Oh, I'm sorry, I don't know quite why this doesn't. Maybe you're going to come and have to change the slides for me. I don't want to take up the time. I don't know why I'm doing it wrong.
We had problems with this a couple of days ago too.
Oh, okay. But now how do you, when you do it, it works, and when I do it, it doesn't.
So I guess just press that button.
I
So
did
what
that.
button were you pressing?
Yeah,
Which button will you press?
I was pressing the central one.
Oh, I guess as hard as you can until it clicks.
All right, I'll try. Okay. This is just a brief reminder of where public health in this country, how it came about, how it's evolved, and the traditional mission, as I'm sure you know, is the control of communicable diseases, particularly malaria. And that's why I found out, looking up CDC, that's why the CDC is in Atlanta, because that's where the southern states were where malaria was when that was founded. Prevention was added to the title in 1992. As I look through the history of the CDC, I don't think any other government agency has had so many different changes of name to reflect changes of what it's supposed to be doing. So it covers a huge range of topics, as you know, including healthy aging, behavioral health, chronic disease. These were not in the original concept of public health, but they are important. Now, more recently, we could talk about population health, which is looking at disparities in health access and outcomes across defined population, and social determinants of health, recognition that population health affected by more than clinical care. And today I read that there are now billing codes for social determinants of health. Now you know social determinants have arrived when there are billing codes that relate to it. Okay. It doesn't, I can't do it. Okay, now I can. So why does caregiving belong in public health? Don't go too far. Well, first of all, it affects millions and millions of people. And it has a major impact on the health and quality of life of both the person needing care, and this context we're talking about older people, and the caregiver too. And although there's a lot of discussion in the literature, the research literature, about whether the effects are all negative, some positive. Definitely there are studies that show there's a negative impact of the caregiver's mental health and physical health. And there's certainly a negative impact on the caregiver's employment, which because caregivers either leave their jobs or don't accept promotions, don't accept further training. They have to be home, basically. And once you do that, you lose retirement benefits, you lose opportunities for the future. And there's a negative impact on the economy just because of all of that. So the social determinants of health really do affect caregiving and the caregiver. And they affect certainly the need for community resources, whether health resources and other kinds of resources. Okay. I don't like this clicker. Can I get it to a clicker? He can do it.
Click the bottom.
The bottom of it. Okay.
Bottom,
Okay.
clicks back.
Okay.
So are you clicking in the center?
Yes. It's the bottom. Okay. Try it.
If you want to do it.
Okay. Let me see if that helps. Okay. Who is a family caregiver? And this is the definition we use. Someone who provides or manages the care of a family member, a friend, a partner, or another person who has a disability or chronic or serious illness. So it does not have to be a family by blood or marriage. It can be a chosen family. And that comes up all the time. Well, you're just talking about family. What about all the people who are not technically family? They are, in the context of caregiving, they act as family. So what family caregivers do, and this, I'm not sure you've heard of these terms, they manage ADLs, activities of daily living, and instrumental activities of daily living. So those are personal care and household chores. And that has been for 40, 50 years, the definition of family caregiving. They do ADLs and IADLs. And that came about through a long, complicated process that was never intended to describe what family caregivers do. It was intended to describe what people with disability needed help with. And the research literature is almost totally based on ADLs and IADLs. But in the more recent history, family caregivers provide what we're calling medical nursing tasks. That means wound care, managing multiple medications. It means operating medical equipment like vents, like G-tubes, a whole range of things that were perceived to be only done by professionals and really only done by professional trained nurses. Family caregivers now do all of these things without training and without much support. They also coordinate care plans among providers. There are lots of care coordinators in every agency. There's one in every, there's a group of them in hospitals. There's groups of care coordinators in payers. There are community care coordinators. But what the family caregiver finds is that he or she has to coordinate the coordinators because they're all monitoring certain aspects of the care, not the whole picture. They manage finance and insurance benefits. They provide emotional support and companionship. That's that little social support that we saw up there in the word cloud. And that's really what families are for. That's the part of being a family member that only you can do, but it gets lost in these other tasks. And it's a long-term commitment. 70% of family caregivers provide between 2 or 10 years of caregiving. And I am not the champion of caregivers, but I took care of my late disabled husband for 17 years. And so that's the trajectory of these things. I'm trying. I think you have to do it.
Sure, just give me a thumbs up.
Yeah, okay. So I'm going to give you some statistics. There are about 43.5 million Americans over the age of 18 who are caregivers of people over 18. We don't count children and teens in this 43.5. We assume that all of these people are adults. We know from surveys that we've done that there are at least 1.5 million and maybe 2 million kids. I mean, 8-year-olds, 10-year-olds, 15-year-olds who are providing a very complex level of care. More than 10 million are millennials, which is interesting because the typical, the studies show, the average caregiver is 49.5 years old and a homemaker. Not all of them. So there are a lot more millennials. They're often taking care of perhaps a parent with a behavioral problem or a grandparent or a sibling. And that's a group that the caregiving world has yet to address because everything is geared toward the middle-aged woman. And these are kids, young people who are at a different stage of life. 18 million caregivers provide assistance to adults over 65. And that's a pretty significant number because those are the people, 8.5 million really need substantial care. The economic value of unpaid caregiving is $470 billion a year. That's a bunch of money. That's the amount it would take if you paid family caregivers at a modest rate, $10 to $12 an hour, even at $15 an hour. But that's a huge amount. And caregiving is universal. All groups have a tradition of family caregiving. But, and this is one thing I've learned through 20 years at the United Hospital Fund doing this work, every caregiver is different and every caregiver needs something that is tailored to that person. Okay, family caregivers, these are results of a survey that we did with AARP in 2011. We published in 2012. We called it Home Alone. And what we found was nearly half of all family caregivers were doing medical nursing tasks, and they had little or no help at home. That there were subgroups of caregivers like employed caregiver spouses, caregivers of people with cognitive or behavioral problems. They did the medical nursing tasks at the same rate as everybody else. Caregivers worry. They worry about everything. They worry about their person's health. They worry about finances. They worry about medications. Am I doing the right thing? Or should this person be off this medication? And they want additional training, but they often can't get it. They get a modest amount, perhaps in a hospital, a modest amount, perhaps if they have home health care, but there are no community resources that are really help train people. Okay. The population health impacts, these are the things that the studies I was referring to. They're limited. They're limited in terms of the time. They're a snapshot of caregiving of a group, particular group at a particular time. Much of the caregiving research has focused on caregivers of people with dementia, which is a particularly difficult challenge. But not all those findings relate to everybody else. But we do find that, and as I said, the research uses outdated definitions of what caregivers do, ADLs and IADLs, even though, and I must say this, some ADLs, like toileting in the ADL list, is different from managing incontinence, which is one of the most difficult things for caregivers to do. And preparing meals is one thing, but preparing special diets, which may mean pureeing, it may mean measuring food to be precise, it may mean certain kinds of things are not allowed, certain kinds of things are supposed to be given. That's a pretty difficult ADL. And forget about the IADLs. They're far beyond, household chores. They are the managing finances and so forth. So we do find that generally caregivers rate their health poorer than their peers. Some studies have shown they have a diminished immune response. In other words, they don't get the same response to a vaccine as someone who is not a caregiver. There's double the risk of heart disease, diabetes, and arthritis, and lower levels of self-care. Symptoms of depression are, I would say, almost universal, at least at certain points. It's not something that caregivers don't necessarily want to talk about, but if you probe, they will acknowledge it. And women are particularly vulnerable to these impacts, and they're at higher risk than men. I don't know why, but they are. The challenges for caregivers, system is hard to navigate. Caregiving and work-family life balance is difficult under any circumstances, but particularly difficult when you're a caregiver, because it's erratic. You don't know when the phone is going to ring and there's an emergency. So you can plan and plan and plan, and then the whole thing falls apart. That's hard to focus on work. At the same time, work is often, I would call, in my experience, work was my respite, because I was doing something that was not caregiving and it was important to me and so forth. But it's hard to balance. There's the financial stress, cost of medications, which keep going up, out-of-pocket costs, transportation, special clothing, technology, all the technology things that are, being touted and are in some cases very helpful. There's a cost. There are family care conflicts about who is going to provide the care, who's going to pay for the care, what does this mean, and disagreements even with the person needing care. And it's a conflict of, it's a tension between the patient's desire for autonomy. I've always lived my own life the way I want to live it, and now you're telling me, you daughter or you son, you're telling me I can't do that. I can't drive anymore. I can't go to the store by myself. What is this? And so there's a tension between that desire for autonomy and the real safety risks and the real kind of, not just safety, but protecting the older person from making some bad mistakes. And we all read about the scams and all read about the kinds of financial abuse that can happen. I know I'm in the category of older person. I get so many robocalls that say, oh, we'd love to help you find a good brace for your wrist. Because I once went on the internet and looked up wrist braces. Yeah, right. Thank you very much. So there's loss of wages. I mentioned all the Social Security benefits and retirement. So it's a big, big challenge to be a family caregiver. And there's the ambiguous role. I assume you know, in professionals are encouraged to practice to the highest level of their credential, of their license. Family caregivers don't have any scope of practice. They do everything that needs to be done, but they're not trained. And they're often called informal caregivers. You probably have heard that term, because that was intended to distinguish family members from paid trained professionals. So they're called informal, as if this was some kind of a picnic, which it isn't. Or they're called volunteers. But one of the things we learned in the Home Alone study, the caregivers said they had no choice. There was no choice. They simply had to do it because there was nobody else to do it. So they're not routinely included in discussions, and there are few incentives for providers to address caregiver needs. It's not easy to build for that. I mentioned the impact of on the economy, and businesses lose an estimated $25.2 billion a year in lost productivity. It's presentism, you're there, but you're not really working. There's recently been a lot of interest among particularly big employers in providing services that will help their employees who are caregivers. And some of those programs are very valuable, but they only meet a small segment of the caregiving population. Hey, whoop. You're doing it. Okay. Okay. So now let's get back to public health, which is why we're here. So why is it of interest now? Well, an aging society, which you all know, the Census Bureau projects that by 2030, older people will outnumber children. And the ratio of potential caregivers, to older adults, in 2010 was 7.2 to 1 for every person aged 80 and older. That's dropped to 4 to 1 in 2030 and 3 to 1 in 2050. And what happens if those 3 potential caregivers, none of them is able or willing to take care of the person? So when we had a big family and they were all close by, there were a number of people who could share the caregiving. Now there are fewer people in that pool, and we are going to be missing some people. Long-term chronic illness dramatically increases the need for caregiving. When caregiving started to be an issue, it was mostly short-term acute illness where somebody got better or they died, and that was it. Now it's for years and years. Also, the survivor of younger population with disabilities is adding to the population that needs long-term help. And I mentioned, the rise of Alzheimer's and other dementia. And that will increase over time. Yes, who's doing it? Okay. In the healthcare system changes, to me, this is one of the most significant changes, and that's a shorter hospital days with many post-acute care needs, whether in a skilled nursing facility, a long-term acute care hospital, or at home. And the emphasis on chronic and controlling hospital costs is leading to much more home-based care, community-based care. It's called community-based care, but what it means is home-based care. It's in your home. It's not in your community. It's right there. And there's a whole movement, which in some ways I do like. It's called hospital at home. In other words, it's horrible to be in a hospital for weeks and weeks and weeks. I was months. I was not the patient, I was the caregiver. But when you get home and you have to do all the things that nurses and aides and doctors did, that's a different story. Even if you have somebody drops by every week or so and says, how you doing? That's not the same thing. The elder care workforce is declining instead of increasing the needs of older adults. That's partly because of the low wages and the hard working conditions. It's not easy to be a caregiver, and most of the caregivers are poor women, often women of color and women who are immigrants. And so that workforce is declining. That's not a good thing. On the other hand, there are increasing use of telehealth, other technologies, which are fine, but they're barriers for some older adults. So, you know, you read the articles, the older adult who loves her little robot, her robotic dog, that's nice, but that isn't gonna make her meals and change her adult diapers. Okay. Linking caregiving to public health is fairly recent in the literature. I dated this 2007 article by Rhonda Talley and John Cruz, both of whom were at the CDC at the time. And they looked at conceptualizing caregiving as an emerging public health issues. And this is what they wrote. There's considerable overlap in the individual needs of caregivers, the foundation of an enormous system of care, and the public health needs of many communities and their members. Also, the better their health, the more likely caregivers are to sustain their caregiving roles. That's true. At the same time, I always try to separate out the reason for supporting caregivers is not just that they're doing something that would otherwise fall on the public funds, but that they're worth taking care of for their own sake. Anyway, this is a very influential article. Next slide. The Family Caregiver Alliance in San Francisco did a follow-up report. No one, to my knowledge, in New York State did a follow-up report. And there was an interesting article in the Indian Journal of Psychological Medicine, which said we cannot leave the responsibility of home-based care to families and hope that the traditional family network is capable of absorbing any amount of stress. It's true in India for sure. It's also true here, even with many more resources. More recently, the National Alliance on Caregiving issued a report called From Insight to Advocacy, Addressing Family Caregivers as a National Public Health Issue. And they had a lot of different reasons for doing so, some of which I've outlined, and also a list of some suggested recommendations. Next slide. I want to turn to what one of the primary responsibilities of public health is surveillance. And in the caregiving world, there is surveillance of caregivers in the Burfess surveys. The behavioral risk factor surveillance system, lovingly known as Burfess, is conducted annually, and it's very wide, casts a very wide net. And their core questions are asked in all states, but the optional models are where caregiving lives. And that means that a state can choose to do it or not choose to do it. And New York State chooses to do it sometimes and doesn't choose to do it the next year. Next slide. It started in 2009 with a screening question, and thereafter, as I said, included as an optional model. In 2015, 24 states, including New York, included the caregiver module in their core questions. And CDC combined the 2015 and 2016 data because not all states participated. Caregivers reported on the intensity and duration of caregiving. An interesting question, those who are not a caregiver in the Burfess survey were asked if within the next 2 years you expected that you might be a caregiver, which I thought was an interesting question to ask. Some surveys ask in the next 5 years, or do you ever expect to be a caregiver, which to me is kind of like Why, how would I know that? I don't know what I'm doing tomorrow. How do I know what I'm doing in the next part of my life? So the purpose is one snapshot, but it's not easy to apply. Next slide. This is the New York State infographic about caregiving, and you can see nearly 1 in 5 adults are caregivers. That's pretty consistent nationally. And there are other statistics about them. Let's see, 90%, 80% manage household tasks, that's the IADLs. Over 50% assist with personal care, that's the ADLs. And 60% are women, that's a little, that's about national. So there we have a real, you know, a good way of looking at what the birth has told us. Next slide. So what's missing? To me, what's missing is that they only ask about personal care and household tasks, but not about complex care. They don't ask about things like complex care involving many medications or wound care, operating medical equipment. They don't ask anything about care coordination or navigating the healthcare system. They ask to choose, the caregiver to choose one unmet list from one unmet need from a list that includes classes about giving care, support groups, individual counseling. To me, this suggests that the assumption behind all of this is that the problem lies with the caregiver personally. They have emotional needs. They're not coping well, so they need someone to talk to. They need a counselor. They need to get with the program and become a more satisfied caregiver. The first article I wrote about my personal experiences was in the New England Journal of Medicine, and it was mostly about navigating the healthcare system and the difficulties I encountered. And one of the published letters said, "Oh, this is really interesting. What she needs is to go to some counselor." Oh, that's not what I needed. I needed somebody to really help me through this system. So there's this kind of, oh, you'd be better if we give you a little pat on the back. Next slide. I want to go quickly through these, maybe not all of them. So some of these regulatory issues affect caregiving and public health, but they're not totally thought through. I think they're lead healthcare professionals to avoid risk of noncompliance, particularly under HIPAA. And I don't know whether you've come across this in your work, but there's a mistaken understanding of HIPAA among many healthcare professionals that they can't talk to family caregivers. They can't talk to family, even if the patient says it's okay to talk to my family. And why is that? Because the HIPAA rules are very explicit that you can talk to family members about immediate needs, about the needs for care, about the diagnosis, as long as the caregiver, as long as the patient does not object. Not clear whether that has to be asked or whether there's some other way of determining that, but it comes up all the time. And it's happened to me when my sister was in an emergency room and having some terrible stomach pains, and the nurse took her into a room, and she said, and my sister said, "I want my sister with me." And she said, "Oh no, she can't come in." Okay, why not? And I didn't want to make a scene there, but I said, okay, I'll talk to you later. And when my sister came out, I said, "What did she ask you that was so personal and private?" She just wanted you to know my health insurance. I mean, really, this happens all the time, and it is so pervasive and so pernicious. So that's one policy. Next one. The CARE Act. How many of you have encountered the CARE Act in your studies? Nobody? Okay. This is the response I usually get. The CARE Act is called Caregiver Advise, Record, and Enable Act. It's a law in 43 states, And New York State's law went into effect April 2016. This is April 2019. I would think somebody might have heard of it. There are 4 basic requirements. The patient has to be, on admission to a hospital, has to be offered an opportunity to designate a caregiver and document the person's caregiver information, contact information, obtain the patient's written consent to share medical information, inform the caregiver about the expected discharge rate, and provide instruction about care at home to the caregiver. Next slide. An impulse created and pushed by AARP after the Home Alone study, and it was a desire to recognize caregivers and give them appropriate information and instruction. But to date, most of the implementation has been around fixing the EHR to accommodate a new field for caregiver, not next of kin, not advanced care directive, proxy, family caregiver. So there's a lot of problems around. There's no indication of when the discharge notification must be given, and there's certainly no compliance. There's no audit of whether a hospital is actually doing this. Next slide. So that's a really important act that almost all state legislators have, after a lot of worrying about it, have passed. But what were they worried about? It hasn't changed anything, except it has created, at least among some administrators, an awareness that the family caregiver is an important person. Paid Family Medical Leave Act, New York State has one of the most expansive paid family family leave acts, and the federal law provides family caregiver leave, but it's unpaid. So it's very difficult to take if you're a family caregiver caring for an older adult. If you're a parent of a new child or an adopted child, that's what it really was intended for. You know, you're going to have this baby and you're going to be home for 3 months or whatever it is. It's difficult. But the New York State law is really quite good. The question is, there are limitations. There's a payroll deduction tax. It's mostly used by new parents, and though leave can be taken 1 day at a time, it's very hard to do that in an ordinary working situation. And employers and HR departments are used to the new baby routine, but they're not used to the family caregiver. So there needs to be employer awareness and buy-in to succeed. Next. I mentioned HIPAA, so we don't have to go over that again. This is something we've just studied, referrals to post-acute care. Because hospital days are so short, many people are going to skilled nursing facilities for rehab or continued care. And we interviewed, there were several parts to the study, but my part was interviewing patients and caregivers about their experiences in discharge planning. And we called it the illusion of choice, because everything was centered around the patient can choose wherever he or she wants to go. But what was the reality? You're given a list of 12 places, say pick one, and you're leaving tomorrow. So this is not much of a choice. So that's online that you might want to look at. I think that's an emerging issue that really has not been addressed until now. Most people picked location, understandably, because they wanted to be close to the person, but also because location is one of the few things that you can actually pin down. You can look on a map and there it is, and here I live, and I can get there from here. You can't measure quality by any kind of a standard that means anything, because the Medicare Nursing Home Compare and even the New York State Department of Health profiles of nursing homes, all based on long-term stay, different sets of criteria. Okay. So I'm going to skip this. because this is really applies only to spouses, even though it's very dear to my heart as a spouse. I think that's probably less interesting to everybody. Let's go on. So there are a few things I just want to mention. Caregiving assessment is becoming a big issue in the public health world and in the clinical world. And most caregiver assessment tools focus on the long-term burden, which caregivers don't like to think of what they're doing as a burden. It may be, but they don't like that term. But this is the Zara burden interview is very widely used. We have a series of a short 3-part tool for hospital community providers that focuses on the immediate needs going home. What can you do? Are you working? What are the limitations? Are you taking care of anybody else? What training do you need? And what worries do you have? And in our interviews, we found that asking people what they're worried about was the most revealing thing, because they were worried about things like, I have to get home, pick up my kid from daycare, to, is my mother dying, to, why has God done this to me? Very broad range of both immediate needs and existential needs. So listening to the caregivers, having them express that was very powerful to me. They're available on our website, okay? And that's the way the website looks, and they're guides to family caregivers, and then there are guides for providers as well. And there's a list of all of them, which I don't know if you're going to be able to have copies of the slides, but as far as I'm concerned, you can if somebody wants to make them available. They're in 4 languages, which most stuff on the web is not. It's for caregivers, it's in English, sometimes in Spanish. We have it in Chinese and Russian. Okay, next slide. And there are a lot of community supports. Nobody really has a very great inventory of them, but they can be either directly related to the caregiver or indirectly through the patient. But they're often under threat for reduced human services budgets. And as you know, the United States spends a lot more on the clinical side of it rather than on the social service side. So, and there's still a kind of tension between medicalizing a problem and, well, that's just, not my department. That's a non-medical issue. So there's a lot of work to be done there, but there are resources. And if you are working in this area, it's possible, if possible, identify a person at an agency that you can talk to, because otherwise you're talking to different people. You don't know what they've been through. You don't know whether they've learned how to deal with the outside call. So it's important to try to identify a person and get to know that person. That way there's a much more human interaction. And we have some websites on guides on that. So looking ahead, I think public health agencies should develop enhanced surveillance tools so that all types of caregivers are included and that all the major tasks of caregiving are addressed. That would be a great help in getting a broader, more comprehensive picture of just what caregivers are doing. The United Hospital Fund and ARP and other partners, we have just completed a resurvey from the Home Alone survey. It's called Home Alone Revisited, and it will be issued this month in a couple of weeks. And basically it confirmed the original study, but it also found some new interesting areas, including pain medication. People are worried about pain medication, and appropriately or inappropriately so. Assessment of family caregivers should be standard practice, and new model should capture the reality of caregiving, and that we should invest in programs that support caregivers, but that actually help them, give them things that they need, that they say they need. And payment incentives for providers would be a good thing. And on the federal level, increase funding for the National Caregiver Support Program as part of the Older Americans Act reauthorization. It's a good program, but it's been level funded for, I don't know, however many years, $150 million, which not a lot of money in today's world. So that would be important. So I think there's one more slide. So public health needs the family caregiver. If you take out that little practically invisible piece at the bottom, the whole system starts to fall down because it's dependent, even though not always recognized, it's dependent on the family caregiver. And that's the last. And I'll be glad to answer any questions, but I know you have other things that are happening, but there's my email, so you can always contact me.
We'll take a couple minutes of questions. I have one I'll start off with, and I apologize if you spoke about this when I had to step out for a few seconds.
Okay.
But are there any other countries that have a better
Yes.
system than we
Yes.
have that we could model after?
Most of them.
Oh, yeah, okay.
All the United Kingdom, Australia, Canada, all the developed countries. Germany has a very good system. They have, but their insurance systems are based on different models. I was just reading a very poignant piece by a British woman whose mother has dementia. And she was describing all the things that are so hard to deal with a person with dementia, losing her memory and all of that. But then she comes to and said, but now she's eligible for an in-home caregiver 5 days a week, 9 to 5. That would never happen in this country. And that's, just assume that that's part of the deal. If you've reached a point where that's the level of care you need, we're not putting you in a nursing home. We're sending someone into your, and she went through the 3 or 4 people who they have and how wonderful they are and how they are lovingly caring for her mother. It was always, wait. The British system counts children as carers they call them. The census asks for carers as young as 8. So they know how many kids are doing all this care. We don't have anything like that. We can't even go near that. So there's lots to learn. I mean, the Scandinavian countries also, but you expect it of them. And Australia has a very, very active and very proactive caregiver advocacy world. And not that every one of these systems is perfect, by no means, but there's a different attitude that this is part of the public responsibility. It's not just up to the family. And I think that's where the difference is.
Thank you. Well, okay, I'm going to be Jerry Springer, so I have the microphone, but if you have a question, let me know. We're recording this, so we want to make sure that everyone can hear your question.
Thank you so much for a wonderful presentation.
Thank
I
you.
have 2 questions. I think the first one, I might have missed the definition of the caregiver. Does it just involve the paid caregiver or also the natural support of the individual?
What I have been talking about here and writing about is the unpaid caregiver. Although there are programs in Medicaid where some family members can be paid, but it's generally the unpaid caregiver. The issue of the domestic workers, the paid help, is a very important issue, but it's not one that easily fits into this framework. But there are organizations that do support and advocate for the paid workers, but I've been focusing on the unpaid workers.
Yeah, thank you. And the second question is in regards to behavioral health support for the caregivers. As you mentioned throughout the presentation, there are different stressors related to caring for someone a loved one, and just not dealing with the individual providing the support, but also dealing with the system that they
Yes.
have to navigate in order to access care and
Yes.
services for them. So are there any, maybe not laws but policies that perhaps, caregivers can have access to mental health services in order for them to not just care of the physical side of it, but also the emotional?
Yes, I would say that there are organizations, and I know there's some in Westchester. The county has some in New York City and state. They're mostly referral kinds of organizations. They'll refer you to. My mother has Parkinson's. They'll refer you to the Parkinson's disease or Alzheimer's. There's very good support, but it's not easy to find always. And my impression is that the hospital staff don't really know what's out there in their own communities, and things change. And so it's a challenge. And often the caregivers don't even realize that what they're looking for is something for themselves. They're looking for something for the person, maybe a daycare, or maybe some kind of a respite. But it's hard. Caregivers get into the mode of thinking it's only about that person. It's not about me. And the feeling of guilt if you do try to do something is very overwhelming. So a lot of recognition and support and permission. It's okay. It's okay to say this is hard to do. Where can I find some help? And having someone who really listens would be very, very helpful.
Any other questions?
Yes, Jeffrey.
Ms. Carroll, as a caregiver, right? I was actually looking through your book, Navigating Your Later Years. I didn't read it, but I was skimming through it. And I was wondering if you could elaborate a bit about how do you engage the person you're taking care of in order to get their business in order, so to speak, as they, because, you have to, like I say, the challenge is getting certain people to like make a will and do things like that that they should do as they're getting older, and you're taking care of them.
Yeah.
So
Yeah.
I want to find out the exact way or how I should approach that, being comfortable. Huh? It's like,
Well, there are certain ways. Telling the story of somebody who hasn't done something and what the trouble the family got into because of that, without saying you don't want that to happen to you, just telling the story, that sometimes will at least pave the way. I don't think it's I'm one of the few people who doesn't believe that Thanksgiving dinner is the time to get everybody together and talk about, your last wishes. I mean, too many people have too much to drink, and it's not a good idea. But another technique is for an adult child, say, who has perhaps small children, say, I really was thinking, we're going off on a trip, and what if something happened to us, and who would take care of the kids? And I'm going to make a will to that name someone. I'll talk to that person ahead. My sister would do it, sort of saying this is what a normal thing in life to think about. What would happen if you weren't able to do it? And then it becomes a little easier to actually talk to the person. But I grant you, you're absolutely right. It's very, very difficult. Now, my mother, on the other hand, had a power of attorney in every one of her dozen handbags, and her living will was in each one of them. She didn't go very far. I mean, she was, in one little town, upstate New York, but she was determined that nobody was going to do something to her that she didn't want. And so the only way she felt she could accomplish that was to make me the one to make those choices. So there are a number of different, you have to deal with the person and know, but it takes time.
Carol Levine, thank you for a
Thank
really
you.
inspirational talk. Thank you. We're going to take a 5-minute break. When we come back, we're going to have our panel convened. And so, there's a men's room I know right here. I think I'm hoping there's a women's bathroom somewhere.
Thank you, Jeffrey.
Okay. And so take a
Oh,
5-minute break.
I'm
I
glad.
have 7:20.
I
We'll
was a
start at
little nervous in the
7:25.
car.
Can you hear me, everyone? Come on, people. Dr. Knapp, I didn't want to call you out, but you forced me. You forced me. Do we have a seat for Dr. Raquelme? Is there a chair for Dr. Raquelme? Wait, there's a chair right here. All right. So we'll go from left to right. Dr. Yankosi, we'll start with Dr. Aaron Yankosi. Dr. Yankosi is an associate professor at Toro School of Dental Medicine, and he's the director in oral maxillofacial pathology in medicine, right? And he's the attending pathologist at Westchester Medical Center, Department of Pathology, and he's the owner of Midtown Oral and Maxillofacial Pathology. All right, you just want to get that out of the way there. And next to Dr. Yankosi is Dr. Etienne. Dr. Etienne is an assistant professor of neurology and an associate dean of student affairs at the School of Medicine here at New York Medical College. He's also a practicing neurologist and the medical director for the Accountable Care Organization at the Good Samaritan. I also interned for that affordable care organization. Accountable Care Organization, sorry. And next to him, we have Dr. Sam Varick. Dr. Varick is a founder and a CEO of MediSprout, right? Which is a telemed company, and it's connecting patients and physicians together, correct? All right. And his vision is to address the shortcomings of healthcare by enhancing one of the cornerstones of the medical practices, which is the provider and patient relationship. Right, okay. And of course, Dr. Valeri, he is the Dental's, ProHealth Dental's co-chair, chief medical officer, and he's also the clinical affairs officer. And he has been lecturing for over 30 years, right? So we thank you for being here, Dr. Valeri. And Dr. Raquelme at the end. Dr. Raquelme is also an associate professor of speech, language, and pathology. And he's also, his recent research included the effects of deep brain stimulation on swallowing physiology in patients with Parkinson's disease. Am I correct? Right. So one of the reasons why we had this diverse panel is that we wanted to talk about the importance of dental health and medical health together, and actually how this is evolving and how the technology is being used. Hence, Dr. Varick in the middle of the whole thing. So if you gentlemen would like to, say hello and pass the mic down one at a time, just to introduce yourself more thoroughly than what I have already. Yeah, we're just gonna say hello, and then I'm gonna jump into some questions here that I have formulated.
Hello. Thank you. You said quite a mouthful already, and good enough. But I'd say I have the pleasure of teaching in this room several times a week. I like it a lot here. It's a nice place.
Yeah, I think the introduction was adequate, but I'll just add, I am from the area, grew up across the bridge in Rockland County, and actually went to medical school here, and glad to be back.
Thanks everybody for coming. We greatly appreciate your attention today. I think this is just a great forum to talk about something that just people aren't talking about in healthcare. Everybody talks a lot about health technology and all the amazing kind of advances that are going on in healthcare, but I think the public awareness of public health with respect to that is really important, and I'm glad we could have this discussion.
So on behalf of Pro Health Dental, we're very happy to support such a wonderful event and support not just the message that Ms. Levine had brought on earlier, but also the bringing groups together. Just to give you a quick little background about Pro Health Dental, our founders had the vision of trying to create a truly integrated model between dental and medical care for our patients. And so we are doing everything in our powers to try and bridge the gap between the two as in treating individuals in a complete manner. All of our centers are either aligned or affiliated with large healthcare systems or medical groups. And we work very close in concert to try and provide the highest level of care. First, by providing patient education, educating our medical colleagues, educating our dentists as far as the relationship. Recently, there was a study published about early onset Alzheimer's disease and pathogens associated with periodontal conditions. So that's just kind of a little snippet of who we are and how we work. We're established in Long Island. We have a relationship with Mount Sinai healthcare systems in Queens, as well as Riverside in New Jersey, and looking to come to Westchester soon, hopefully in the near future. So glad to be here. Thank you.
Great. So first of all, I'm glad to see this is an interesting panel on what we're going to talk about. Because from the speech language pathology standpoint, especially in the context of aging, we don't talk about this enough. And there is some great data out there about its impact on overall health, aspiration, pneumonia, et cetera. So I'm sure we'll get to that later. But I also just wanted to mention that in addition to having fun here at New York Medical College as an associate professor in speech language pathology, I'm also director of the Center for Swallowing and Speech Language Pathology at New York Presbyterian Brooklyn Methodist Hospital. So I get to see patients on a regular basis. Our students go down and do regular rotations at Brooklyn Methodist. And so I get to work with people and students at the same time, which is the best thing in the world.
All righty, so let's jump right in. Dr. Yankosi and Dr. Valori, I want you to tell us, right, as best as you can, when it comes to taking care of our teeth, how detrimental is it to our health when we do not take care of our teeth and we develop certain things, oral hygiene, that hinders us? Just tell us.
Well, as I alluded to earlier, there's a very strong correlation, not just between the periodontal pathogens and early onset Alzheimer's, but as well as cardiovascular disease as well. You know, birth weights, you know, there are a whole myriad of issues with poor oral health, you know, and many of them need to be first brought to the forefront educationally, and again, addressing it in a full public manner. That's why, you know, this kind of forum is tremendous to have this conversation.
Yeah, I'd say that's absolutely right. In terms of a number of diseases that are the data that's being elucidated to show quite a few conditions that affect public health that are related to oral health. You know, from, like you mentioned, Alzheimer's disease, which is a relatively recent finding, and there's both a biologic mechanism that's at least been postulated for that, as well as data that's been looked at in terms of looking at patients' tissue and finding that there's evidence that brain tissue has actually been affected by bacteria from the periodontitium. And I think that one of the things that really gets missed, you know, I see patients here in the dental school, and you know, it's somewhere around 40% of the general public has periodontal disease. And I just feel like people know about cavities because they hurt. Periodontitis, it just doesn't hurt. So you can go around with periodontitis for years and years and years, and you just don't know it's there. And the public's not very well educated about it. Whereas with a cavity, you get a cavity, it hurts, you get a root canal, you get the tooth pulled, and then it's gone. Periodontitis is such a bad disease. It's a chronic condition that will stew along for 30 or 40 years. And again, the patient doesn't have any pain, and so they're not aware of it. And just to, again, to mention some of the diseases that have been associated with it, cardiovascular disease, preterm birth, low birth weight, preterm birth. Even in one of the main texts on pathology, they reference it as one of the possible triggers for rheumatoid arthritis, which is a relatively rare disease. Anyway, I think that people know a lot about cavities. Of course, there's still a huge problem in this country related to dental decay, especially in the pediatric population where it can be prevented. But my feeling is periodontitis is something that we just need a lot more education for among the public. I don't know if any of the other panelists have some more to say.
Yeah, so interestingly, I think we've talked about the importance of basically bridging, getting people to communicate, talk to each other. And actually about a little over 10 years ago, after I finished my neurology residency, I decided I wanted to go back to school to get the master's in public health. And while going through that program, one of my colleagues who is, he's a neurologist just like me, and like Dr. Amler, his father was a dentist. And when it was time to do our master's thesis and come up with a project, he made the decision that he was going to use the NHANES data set and study the relationship, which we guys alluded to that study. It was actually one of my colleagues at Columbia Presbyterian who actually started researching this. And he wanted to see if there's any relationship between, your oral health and dementia. He's a dementia specialist at Columbia. And he actually did find that relationship. I was astounded. I said, wow, that's interesting. And so because of that, the various different mind, well, it was really one mind. It was the son of a dentist who happened to be a neurologist. But that just stresses the importance of us communicating and collaborating, because this finding makes it so that now in my office, in a neurologist's office, I can actually start talking about the importance of oral health. Because otherwise, I wouldn't really be stressing that, and because it just wouldn't really fit. Like, why are we talking about my teeth? But when I talk about that, but yeah, that's what we learn in med school. You get brain apps, all these kind of things. So definitely, from the neurologist standpoint, we think it's extremely important that this research goes on, and really, this is just relatively the beginning. So we want to see what else we're going to find in the future.
Add one more thing. We forgot to mention diabetes, and particularly type 2 diabetes. There have been some just there's very strong data that shows there's actually a two-way street with diabetes and periodontitis, where patients improve their periodontal condition, glycemic control gets better. If they improve their glycemic control, periodontitis gets better. And actually some studies looking at insurance data have found there's significant annual health savings for patients who are type 2 diabetics that just get the very basic periodontal care, which is commonly known as a deep cleaning. If they get that, the cost of caring for those patients goes down significantly, particularly for diabetes, but as well as some of the other conditions we mentioned, cardiovascular disease, low-term birth weight, and so forth. But especially diabetes.
So just as we're looking at a few of the clinical populations, the other big aspect in the context of aging is also the fact that many medications have side effects that cause xerostomia or dry mouth. And that, of course, then creates a great environment for reduced oral hygiene, other periodontal disease, and so on. The concern is when we're looking now at the aging population, and as we know, the group that's growing the fastest and has been now for over a decade in this country, is that these are also people that might have swallowing difficulties, right? And so then they might end up on modified diets, or what we don't like, which might be feeding tubes, right? And so many times, if they haven't been worked up properly, they might end up with let's say a gastrostomy tube, right? A feeding tube in the stomach. And if they didn't have the full workup, the idea might be they can eat nothing by mouth. What does that lead to? Then that also leads to a dry mouth and a horrible oral environment, which then also leads to a higher rate of an aspiration pneumonia. And aspiration pneumonia is the 4th most common cause of death in people over 65 in this country still, which is horrible. And it's over 80% in people with Parkinson's disease. So it's very multifactorial, and that's why I'm glad we're talking about oral health, because in our practice in speech pathology, we've had to start talking about that too, and form new relationships with our dental clinics at our facilities to say, listen, you know, this is this person with dementia. Nobody's thinking about their teeth. They're concerned about their special diets. They're not developing a pneumonia. They're toileting. There are other issues. And yet this is a big, important aspect of it. It's not just the beauty of having nice white teeth.
Also in that same vein, I'm a prosthodontist, which is a specialist in restorations. And I'm also a maxillofacial prosthodontist, which means I make special prosthesis for head and neck cancer patients, whether they're oral or extraoral prosthesis. So very happy to be sitting next to a speech person. But one of the things I want to touch upon is caregivers would respond to sometimes the xerostomia that patients have by trying home remedies to resolve it. And oftentimes they're really inappropriate in that they're sugar-laden lozenges and such, and that just makes the process of developing caries much more rapid and rampant in these patients. So again, part of the education process, whether it's with a caregiver or with the patient themselves, it's been my experience in practicing for over 35 years now that to see those patients that up to a certain point had wonderful hygiene and respected their oral health, from just making a poor decision or somebody making it for them to try and combat the variety of symptoms that occur with xerostomia of varying degrees, you know, it just brings them to a much worse place in a journey than they ever could imagine. The other thing which you hadn't touched upon, which I just thought of is oral cancer, which although it affects probably accounts for about 5% of diagnosed cancers. Orally, it again, significant symptoms. We're actually embarking on a potential study with a new technology for diagnosing oral cancer right now. We historically, clinicians like myself use you know, digital and visual analysis to look at lesions. We also use a light source as well. Clinically now, our hygienists use it as well as all of our clinicians. But there are other technologies that are coming to the forefront now, which look much more promising to, again, early detection, which is key to minimize really debilitating situations.
Okay, so
Yeah.
Dr. Verk, I was going to get to you.
No,
You grabbed the
Go
mic.
for it. I can talk about it.
Yeah, he
Something else,
jumped my
sir.
questions, but
I
I wanted
yeah.
you. I got
Okay.
a question here because I wanted you to explain how and why telemedicine has changed and will change the field of medicine, especially when it comes to the patient and practitioner relationship.
Sure.
Okay.
Yeah, no, I'd love to expand on that. Just as a quick kind of add on here, you know, when you hear these topics being talked about whether it's oral care and the consequences of poor oral hygiene, you know, it always takes me back to something that's very basic in healthcare from a public health standpoint, is the idea of just prevention, right? How do we make sure we are better advocates for prevention, because we live in a very reactive healthcare environment where we end up addressing needs and issues after they've occurred. So, you know, in my practice, when I was practicing, I would see this over and over again, and the countless times that I would see patients and wonder what could have been accomplished if there was a better strategy towards prevention, was something that kind of I think we just all have to work on. So that being said, in terms of telehealth, yeah.
Make one last comment
Yeah,
on
Doctor.
the teeth part before we move on. The oral. So one of the because this is we're talking about public health, and one of the, I don't want to leave this topic before talking about a little bit about social determinants of health. So one of the things that happens is that, so we're born with 2 arms, we're born with, you know, 1 brain and 1 heart, and how many teeth? 32 teeth or something like that. So what happens is you know, a lot of us, you know, if you make, you know, decent money, you didn't take care of your teeth, you're going to get them replaced. Okay. There's a large segment of the population that if they don't take care of their teeth, they will not be replaced. Okay, they'll be left with no teeth. They'll start from 32, take some out here and there, and all of a sudden you've got like 5-6 teeth in your mouth. And I have one patient I recall vividly who actually had to go on a feeding tube because of the fact that she just didn't have teeth and she couldn't afford to get anything put in her mouth. And she ultimately died within a year or two. She was looking for all kinds of services. It just didn't happen for her. And these patients, I mean, they are dying sooner because they have to change their diet because they can't chomp on a steak. They might still try to do it. They're going to aspirate. They're going to choke. They're going to have all these kinds of bad things happening. So it's extremely important. I just want to make that point before we leave this area.
All right.
So I'll just pick up on the question you were mentioning about telehealth and
Right.
where it is now, where it's going. And so telehealth means you ask 10 people what telehealth is and you got 10 different answers. That's the first thing, right? Is it a remote device? Is it my Apple Health app? Is it a video call with my doctor? Is it remote surgery? There's tons of different kinds of telehealth, which is just a remote application of healthcare, right? The way that we view telehealth at the company I've created is the notion that you should be able to get care from a doctor who knows you, your own clinician who you have a relationship with, particularly people with chronic conditions, but you should be able to do that remotely. You shouldn't have to go into the doctor's office for every time you need help, but it should be the doctor that knows you or the office that knows you, right? So the idea behind telehealth, where it is today, is it's just getting off the ground in terms of how people get connected to their clinicians remotely, whether it's their dentists or their doctors, whoever it might be. So I think that's the first step, is getting people connected to medical providers with whom they have a relationship. As I mentioned earlier, there's this whole vision of technology kind of taking over and replacing all of us, right? But the reality is that isn't happening yet, and that may not happen for many, many years. And we have to deal with the environment we have now. And the other reality is those relationships do matter, and they are significant. So the question is, how do we apply technology to those relationships in a way where the data and the relationship can come together to make the most powerful impact in people's healthcare that we can today, right? So the relationship is there that we have with our clinicians, but the technology isn't being applied to that relationship the way that we want. Because honestly, healthcare is way behind in terms of how we're applying technology. We view the idea that your whole physical exam can be done on this phone. Today, all devices can be mediated through your telephone, but people still view healthcare through the lens of a stethoscope, right? Or an otoscope, which are great. They're wonderful tools, but we should be able to move this forward and apply that relationship so that we can use our devices to do everything that we need in healthcare. And the exception should be going into the doctor's office and seeing your doctor.
So Dr. Varick, MediSprout, what is the relevancy of MediSprout to public health?
The relevance of public health is it promotes the idea of continuity of care, that continuity is important. We live in a world of healthcare now where we are relying increasingly on urgent cares or CVS or Walgreens or doctor on demand to get our healthcare. And the reality is, for our most pressing healthcare needs, whether it's diabetes or hypertension or heart disease or asthma or GI disease, those models don't create the long-term impact that we need as a society to effectively help people with those diseases. They actually end up increasing costs of healthcare because people are getting one-off healthcare needs met, as opposed to getting those healthcare needs met with their own doctors. So continuity of care, but making it easier and more accessible. That's really what kind of our company is focused on.
Okay, so
Just to help put that in perspective in terms of an actual patient. So I'm one of the funerologists around who I still make house calls. And why do I make house calls? Because I don't have your company helping me. So what happens is, and I don't make a lot, I mean, I'm very selective about which patients I'm gonna make a house call for. You can't just, I don't advertise it. I don't put it on, hey, come see me. I'm gonna make a house call. These are usually patients who I've been following for a few years, and they're no longer able to come to the office. And these are typically going to be patients who have ALS, like Lou Gehrig's disease, advanced Parkinson's disease, and advanced dementia, where it's really, and when you go to the patient's house, I actually like the house calls. When you go to the patient's house, you have a much different level of understanding of the patient. I have a much greater appreciation for how hard it is for the families to cart them into a minivan or a bus, ambulette, whatever it is, to get them to my office. And I see that and say, wow, I'm going to come back and see this patient and take care of them. I walked into one patient's house once. The lady was in status epilepticus, and I felt like I had a little ICU all of a sudden, running in this bedroom. But this is, that's how medicine used to be. And I like it. I like the personal touch. And I think, if I had this type of system, a lot of what I'm doing really could be done, via the phone. For me, the patients are kind of near, not far away. This is very useful for patients who are far away from you, who it's very hard to travel to. Like people who are, I've seen doctors establish long-term relationships with patients in other states, where you're the same doctor over and over, whether it's in Montana or other underserved areas where they don't have regular access to physicians. So that's why that's where the telemedicine comes in, at least from the neurology standpoint.
Okay, Dr. Raquelme, I got a question for you.
See, you should have asked the question first to see if I'm going to or not.
We have a question in the audience? It's not question time yet. Hold your question, make a note. We're gonna come to you, I promise. Dr. Raquelme, when, we're gonna switch up a little bit here, but when I was thinking, I know that SLP, right, has a lot to do with cognitive treatment, right? And when it comes to such ailment as dementia, can you please describe how cognitive treatment makes a difference in our aging society?
So first of all, cognitive treatment and cognitive therapy, it's just a very broad category, and we still don't all agree in healthcare. I mean, occupational therapists work on it, neuropsychologists evaluate it, but don't always do the therapy. In speech pathology, we assess it in the context of communication, and we look at it, as it's tied into language and the way we process information. In persons that have been diagnosed with dementia, and let's just start from here, and please, if anybody on the panel disagrees, just jump in, but we're not doing a great job at even determining the type of dementia so that we can start to understand the differences. Because I know certainly in terms of swallow breakdown, there are differences between a person with Lewy body dementia, frontotemporal dementia, or Alzheimer's dementia, which is the only data we have right now, and there are the other dementias. So first we have to deal with that, because basically right now in the US, anybody with an MD or DO degree can diagnose a dementia. I hope best practices would knock in their head and they wouldn't do that. They would send them to a neurologist or a psychiatrist. But so that right there is the beginning. We don't always get them early enough, right? So many times because we're in a society where we're comfortable with, my loved one is just forgetful, et cetera, until things really start happening. And then we also have the complexity of delirium. So older folks being admitted to the hospital, becoming delirious, not having a good medical care team that can figure out, is it dementia, is it delirium, which then complicates their care as well. And these are the folks that end up with many other issues. Now let's go to if we're gonna treat them. So let's say it's a real dementia, we're going to do therapy. No, this is not somebody that if they're having word retrieval problems, I'm gonna work on naming like I would with somebody that just had a stroke, okay? However, our role would be in figuring out what their strengths and their weaknesses are in terms of communication. For example, depending on the type of dementia, many times reading and writing are the last to go. Right? So we can use that as a facilitator. So can we figure out a communication system right? For now, and then train the caregivers on how to best communicate with their loved one, whether it's instead of asking open-ended questions, starting with yes/no questions. Maybe if this person is writing better, then allowing them to write what they want or getting them involved. And having a schedule that we've seen over and over again helps out. So they're home all the day, the caregiver is busy doing 20 things, but if they can get this person on a schedule, so after breakfast, we're going to do this, and then we're going to exercise, and then we'll do that, and then they have a routine, we see that there's kind of a delay in the decrease in cognitive functions. So those are just some of the things that we might look at. If it's early on, and especially in folks younger than 65, that we start seeing cognitive decline, many times we will incorporate computer games and more direct treatment because we have to figure out what types of memory are breaking down. And that's very often where the speech pathologist and the neuropsychologist work together to figure out exactly where those breakdowns are and how we can get in to help them maybe recover or retain some of those skills. How's that?
Okay. All right. Okay, so the next question is it's open to everyone, but I think, Dr. Miller, you're probably the quickest to get on this because you have an MPH degree, right? So in public health, we're big on preventative care, preventative medicine. So I want you to elaborate on how imperative it is for not only the aging population to practice preventative medicine, but reason why it's so important for all of us to take into consideration the preventative steps necessary to have a healthy being.
Yeah, I mean, in general, I think we've kind of covered a lot of that here when we talked about the oral health part, but really that's partly what made me, after my residency, go back to school to get an MPH, was that I was, on the stroke service, seeing one patient after another coming in with a stroke, and helping one patient at a time. I like doing that, but it's important to find out how can we prevent that in the first place. So modifying, taking care of the blood pressure, the blood sugar, the cholesterol levels, telling people to have a good diet. I generally recommend, especially if you have a family history of any kind of dementia, a Mediterranean diet. Being careful about what you put into your body so that you can have your brain. I said earlier, you have one brain, so you want to try to preserve that for the duration of your life. The exercise, going out for, even if it's just a walk, every day is important. So yeah, those are all key. The United States healthcare system has been shifting towards preventive medicine for a reason. You mentioned that I'm the medical director for the ACO. The ACOs, which is an accountable care organization, their main job is to find ways to save Medicare money so it doesn't go bankrupt, as people keep talking about. And the way to do that is to, how do we prevent people from falling down, doing all those types of things. So I think it's, obviously it's critical that we do practice preventive medicine.
Good. I'll go after you.
I think the other thing that's critical is lifestyle, and it was alluded to earlier about some of the stresses that certainly caregivers have. But in terms of the topic that was discussed earlier, but I think it's interesting. I have two teenagers that are in high school, and they have mindfulness that the kids are educated in. They also have a very different perspective on how they want to conduct their lives in terms of wellness, and not reactive medicine, but preventive medicine. And I think all of that is very different, certainly from the way that I was when I was that age. And I think that's another critical component to it. And again, I would support that perspective as well.
Yeah, I think, for people in everyday life, getting preventive health care is hard. It's just hard. It's much easier to walk into an urgent care, or walk into, as I mentioned earlier, CVS, or just go online, or just ignore it, right? It's a pain to go in and monitor your blood pressure every month and adjust your medications. And and especially with our lifestyles today, it's become, so there's two contradicting parts of our life right now. Our lives are busier. We're doing more than ever because we have access to technology that makes us more productive. But at the same time, our medical treatments are becoming more complex, right? And when you have these two diverging mechanisms to, manage your healthcare, but other aspects of your life are busier, you're not going to spend the time doing it, right? So the question that we have to answer from a public health standpoint is, how do we make prevention easy? How do we simplify it, right? And people that can come up with those solutions, it's great. I think the ACO framework was a great idea, and I love the fact that the government is trying to create mechanisms to make it easy. But the reality is, it's not working well. The latest data on the ACOs shows it's kind of gotten mired in bureaucracy. Many hospital systems created ACO organizations for the glamour of saying, hey, we have an ACO, but the data is showing they're not effective, right? I think there's a lot of private companies, organizations who are driving this reactive healthcare model. We need to start promoting and energizing companies for preventive mechanisms of healthcare that work outside of the government models, that really start pushing this. This is one of the reasons that I went into telehealth, was because I thought there's this huge opportunity to create this mechanism of prevention where the first thought on people's brains isn't, should I go to an urgent care? But the first thought should be, I need to get connected to my doctor right now, and they need to guide me with what I need to do. If we can create that change in thought process in the way that people think, then we will kind of take that step towards prevention that really makes an impact.
Yeah. So the truth is, so whether you're talking about an ACO or telehealth, in terms of the public health impact, it's not going to be the big splash that we're looking for. So how do we really make that big splash in public health? So the less that you have to think. So if I have to think about it, I got to make a phone call, or I got to go to the ER, the urgent care, whatever it might be, my doctor's office, less impact in terms of on a population level. So where's the big impact? So not having to think about it. So in Canada, for example, they wanted to address the neural tube defects. People can get, when the nervous system is developing, some babies are at risk for that. So Canada this is like maybe 15 or so or 20 years ago, they started fortifying their cereal with folic acid. So that basically every young woman is automatically, as long as you eat cereal, you're gonna have folic acid in your system, you get pregnant, your baby's protected. You don't need an ACO for that. You don't need to call somebody. You don't need to do any of that stuff. It's just automatic. How do you go into New York City, you look at some neighborhoods, richer neighborhoods, there's a fruit stand on every corner. You can go to the supermarket and get, healthy food. You go to the poorer neighborhoods, what's there? Candies and sodas and juice, so that it's much harder for those people to actually get good food and have good health. So the less you have to think about it, the easier it is, and the bigger splash it's going to make, because it actually affects the entire population all at once.
I just wanted to mention, I think, so we need a culture change, right? So, and that sounds easy, but we need more funding for healthy aging research, so that we really know what healthy aging is supposed to look like, and maybe what we think it's supposed to look like, and we know what to promote. But I think also in terms of changing the culture, it's how do we facilitate things? It sounds great for me to tell an older person, or my physical therapy colleagues or physician colleagues, say, you need to exercise more. But if it's not part of their mindset, even if they have a gym nearby, they're not going to go. Then they go to the gym and everybody's in these great bodies in spandex, right? And so then where's the space for the over 50 crowd and the machines that the over 50 crowd can handle without feeling self-conscious, right? So that's one piece. I go through that in terms of culture change, and I have colleagues that'll say, oh, I tell my 80-year-olds they need to drink more water. Why? They didn't have all this stuff around, their generation. For them, yes, I'm drinking enough I was having 4 cups of coffee a day, or they would have a Coke. And we know that the caffeine further dehydrates, right? So how do you start incorporating better hydration which we know is a problem. And again, side effect issues with medications in terms of changing that culture for folks. But we need to aim in a direction of the things that we know and facilitate. And I love the fruit stand issue because.
Okay, Dr. Yankosi and Dr. Valori, you're both oral care experts, both oral pathology experts. Can you enlighten us on maxillofacial surgery and the ways that we can avoid certain oral sickness as we get older? And emphasize just how oral care is a real public health concern. I know we've talked, but I want you to directly tell us from this question, describe to us what it is. And
Well, maybe I'll do if you want, I'll do the first part about avoiding major surgery. Well, it's interesting. A few years ago, this study came out that said, screening for oral cancer isn't cost effective. But I don't know how many of you saw that data. Maybe you're familiar with it. It was really somewhat misinformed, because that's saying that you take the population who's not already going to the dentist for the regular exam, and then you grab everybody for a separate visit to go to the doctor's office to do an oral cancer screening. But that's actually not the case. The oral cancer screening should be part of your normal DO 150. Everybody should get, which is the the dental code for it. So everybody should be getting that. Oral cancer is probably the one that you end up with major surgery for. I mean, look, this is a disease that most of the vast majority of cases, it comes from a precursor lesion that can be identified on a clinical tactile evaluation. And the ADA has shown this very clearly in a publication in 2016. If the dentist who is seeing the patient does a thorough examination, looking at all the oral tissues, if you're trained to do it, it takes about 60 seconds, you can identify the small white patch that can simply be biopsied and removed before it turns into a cancer. And yeah, there are a handful of cases here and there the biology is just such that you take it away, it comes back, take it away, it comes back, and eventually, leads to the demise of the patient. But that's really few and far between. And so really, it's a matter of getting into the dentist's office and having a clinical tactile evaluation to avoid the major surgeries. So that handle the first part of the question?
yeah.
All right. That's on.
I concur.
All right, so I'm gonna ask one final question, and I think that we're gonna turn it over to the audience after that, okay? But since I got all the doctors up there in the different fields, I wanted to know, how can we be more inclusive in the healthcare field? How can we be more inclusive? Since I know that's a little bit off, but I want you guys to ponder that for a quick second, and then tell us what you think about that question. I know. That was a little curveball.
It's going to be really simple. So first of all, I think we need to respect and refer to geriatricians who know so many great things. And then the other piece is also to make sure that as healthcare providers, we know our network and who the other people are around. There are still physicians, for example, diagnosing aspiration pneumonias, not sending the patient to the pulmonologist, not sending them, maybe to the speech pathologist to see why they're aspirating and when, and, to figure out how to prevent it from happening again. So maybe making sure that we create those networks where we're all comfortable with each other and we can talk to each other.
I think somewhat it's a mindset in the world of dentistry. We're looked upon as procedure-based technicians rather than true diagnosticians and caregivers. And unfortunately, insurance carriers look at us the exact same way, because every procedure we have is associated with a product rather than diagnostic codings. And so the public looks at us in very much that same way. So again, part of our roles as caregivers is educating patients as to the critical nature of having a proper exam and diagnosis. And I think communication is critical with our patients, with our colleagues, whether they be other dental colleagues that may be specialists, and or our medical colleagues and support people as well. So with the word communication and collaboration, I'm going to pass it to you.
being more inclusive in healthcare. That's a question, right?
Yes. How can we
Um,
be more inclusive in the health?
we have to have massive insurance reform. I mean, whether that's universal coverage or whether that's, you know, whatever it might be, but something that breaks down our mechanism of insuring people. It creates disequality. It's a disingenuous system with mechanisms in place that make it easy for people who can afford good insurance, and it makes it hard for people that don't have good insurance. It's and when you live in the world every day, you see it. You see the realities of it. And I've seen the realities of it with the company we're dealing with. We go to some medical offices in certain socioeconomic areas where people cannot afford insurance, and they say, sorry, we just can't afford the kinds of technology that need to be put in place to help patients. You go into other places, they say, yeah, no problem, insurance will cover all of it. So that's, you know, in a ballgame.
Since you brought up insurance, dental insurance is really not insurance. It's a stipend. And it's usually a very, very minimal stipend. And again, just anecdotally, in my experience in dealing with head and neck cancer patients, in creating obturator prostheses to replace parts of the mouth, palate, patients can't function, they can't swallow, or even speech prosthesis. As a dentist, the dental insurers or the carriers don't recognize these prostheses as really anything other than if a patient has a denture, where they have tremendous functional value. So if a patient doesn't have that coverage, and it's very unique that they do, then there will be no compensation for the patient and or the provider. And for most of us that treat these kinds of patients, we do it typically, you know, without any fee. So that's another issue in terms of insurance, because it doesn't truly exist in the dental world at all.
So I'll just comment on two different aspects of inclusion. One is already alluded to, which is, you know, in medical school now, when we educate our medical students, we stress the importance of interdisciplinary management of the patient. So we want to have, you know, and we grade them on that so that students understand it's important. So including all the various specialists, physical therapists, occupational therapists, everybody, speech and language pathologists. I've got very close relationship with our people to take care of patients. That's one. Two, in terms of from a societal standpoint, how are we more inclusive? Whatever we can do to minimize the social determinants of health will make things more inclusive. So that includes getting rid of the insurance barriers. So I had the privilege years ago of working in a military healthcare system where everybody has the exact same health insurance, from the lowest ranking private to the 4- and 5-star general, to the President of the United States, to the Supreme Court, to the congressman. They all have the same insurance called TRICARE, and the same exact providers. So it's not, well, this is the VIP patient, we're gonna get the special doctor to see this one based on your insurance. Everybody has the exact same people. So in my office, you know, I would have the I'm Navy, so 3- or 4-star admiral walk out the door, and the next person coming in is a seaman. And one of my colleagues, who's an OBGYN actually, and this is probably one of the, I would say, the purest place to actually, I'm sure somebody will argue with me about it because there's always debate available, but probably one of the purest places in America to actually evaluate for things like racial disparities. Because when you eliminate a lot of the other factors, now you can actually see what is the true impact of race on healthcare. One of my colleagues did a study, she's OBGYN, on ovarian cancer survival amongst women who have TRICARE. And she found no difference between Black and white patients. Whereas in the civilian literature, there are big differences that Black women don't do as well as their white counterparts. So those social determinants have a huge impact. No matter how much you try to minimize them or say they're not there, they're there. We talked about caregivers earlier. When you've got care, you know, the patient is coming from the exact same environment as the caregiver. So the caregiver is going to be probably at risk for the same thing you're caring for that person. I remember after the earthquake in Haiti, when I was down there providing, disaster relief. And, every patient who came on, I was on the USNS Comfort, every patient who came on the ship had to have an escort. I was chief ethicist. And I put that rule in place so that in case it's gonna sound morbid, in case the patient dies, somebody can go home with them, can take them off the ship and do proper burial services. But what was interesting is a lot of times, the caregiver, the earthquake happened, so they were in the same environment. So a lot of them had fractures themselves, but they were more concerned about this other person that they were caring for. And I would see them walking away with a bone literally sticking out of their skin. But they're here to take care of this other person. So these caregivers that we've talked about earlier, and it's not maybe not as dramatic here in the U.S., but they've all got their own set of problems that they're dealing with, that they've actually put aside, and they're taking care of this other person. Anyway, that's my take on that issue.
I think my colleagues did a very elegant job of responding to that question, so I'll just leave it at that.
All right. Okay. So let's turn. Any questions?
Sure. Sure. Good question. So I'll just repeat the question. So you're asking, how can we get people who may not be as tech savvy, whether it's elderly people or otherwise, how can we get them up to speed so they can actually benefit from these technologies? Yeah, no, it's great. It's a question we get all the time. We work with the visiting nursing service and other organizations who manage elderly patients, and it has to be one-on-one assistance. We tried to our solution anyway. I hate using that word. We try to dumb it down or simplify the solution so it's easy to use, right? But it's never easy enough. And so you actually need somebody hands-on showing the patient, whoever it might be, whether it's child or elderly person, or you need to show them how to use it. And that's a challenge. That's a unique challenge in every environment that I don't have one answer to. We usually will work with whatever organization it is and create an infrastructure. In the VNS, for example, it was a matter of educating the nurses who were going into the homes, and they would then show the patient on an iPad how to access care, right? So there is a level of learning that has to take place. It's like any new technology. When people learned to do online banking, when it first came out, this was the exact question everybody asked. How are elderly people going to online bank? Eventually they did. They figured it out, or somebody ended up having to show them. But to answer that, it is unique in each environment, and it does have to need to be addressed. Sure. Yeah, HIPAA compliance is tremendous. These days, it's the first question we get. HIPAA is the Health Information Patient Portability and Accountability, right? So you have to meet certain standards of privacy and data security where we and all companies are vetted by outside organizations to make sure we meet those standards of compliance. Does it mean that we are completely secure or everybody's, no, it doesn't. And the risk does exist, absolutely. You see, I mean, every week there's an article in the paper about some organization paying a fine because of privacy breach, right? The problem with HIPAA is they are just, they're not standards, but they're recommendations, right? So even if you meet the, so as a private company, the frustration is, even if you meet the recommendation, it doesn't make you, it doesn't prevent you from being fined or cited. So it's a tremendous challenge. Data security and privacy is obviously at the top of everybody's mind because it affects so many things. But all we can do is try to meet those standards as best as we can. Sometimes we go beyond it, but there will always be somebody who's going to beat that, who's going to be able to breach.
It probably has the same impact if you have electronic records in a private office. You have the same potential breach there.
Yep. Yeah, exactly. Like he was mentioning EMRs and EHRs, they also have the same, you know, the same risk and liability of being breached. There's no way to prevent it. There's always going to be somebody who's ahead of the curve and going to be able to get what they want. So I think you have to go in knowing that. And you have to go in, same way I input my credit card when I'm buying something online, I realize that risk is there. And it could be Amazon, it could be any company that can happen to.
Yeah, I mean, the thing is, it's not perfect, but it is the way the future is going. Right now, you know, Columbia University, for example, in the ambulances in New York City, they've actually put telemedicine inside the ambulance, because when somebody's having a stroke, the quicker we can evaluate the patient and decide if they're a candidate for a clot buster called TPA, and then do a clot extraction, the better their outcome. So, and we've been cutting down on the time over and over again. Now we've gotten the time so low in the ER, we've said, you know what? Instead of the ER, what about the ambulance? Let's start the evaluation while they're en route to the ambulance through telemedicine. Because that way, as soon as they get through the ER door, we've already made our determination, and I think they have a CAT scan machine on the ambulance now, so that by the time you get through the ER door, the TPA is ready. So as soon as you come in, you're getting injected. Because there's no need, you know, if we have the technology, there's no need, you know, I'm not gonna be as worried about this technology breach as I am about saving my grandmother's life. Because if I can break up that clot and get her back to fully functional, then I don't care if somebody else tapped in on it and saw what was going on, because now that's going to be less likely that she's going to need a caregiver, which is an additional drain on the economy. So I embrace it. I don't think it's going to be I personally don't think it's going to be our full healthcare model, but it's going to be a big part of our future.
Any other questions? Doc.
So with any procedure that we do with our patients, you have, I believe that you have to educate the patient into the risk benefits, whether it's a simple filling or it's a biopsy, and then you have to establish that relationship. Granted, under those circumstances, if somebody's in intense pain, they're less likely to be interested in what your rapport is, but it doesn't mean that it's not as important. In a practical sense, if there's a lesion that's suspicious and they need an extraction done, why not do them both at the same time? One surgical experience, and actually it's probably in the interest of the patient to consider doing that. You know, when you know, with any kind of potential cancerous lesion, there are two ways patients seem to go: either seeking immediate care, can't happen soon enough, or patients that are in denial and you'll potentially never see them again, whether it's an oral cancer potentially or any other type of cancer that there may be potential for. So again, I think a lot of it has to do with the presentation, the interaction, and the understanding and how you educate the patients. And that's been my experience quite anecdotally, but that's how I would manage it.
Yeah, I'd echo that salesmanship with your patient, you know, being able to get them to buy into what you're saying is, I think that's just a part of doctoring. And then, I mean, heck, it's so funny you asked that. I just got back from my practice in Midtown and I had a patient with that exact same issue today. She came in, they didn't know what was causing the problem for her. She had an abscess, and it's like, oh, well, it's an abscess. I have to have that tooth out. But then I identified 3 red and white plaques in her mouth. So anyway, she actually is a physician, so she was happy to go ahead and just get the biopsies. So I did a few biopsies on her. But anyway, I think, yeah, you know, if you already have the patient now, that kind of situation, easy sale.
All right, so we're gonna wrap it up. Okay, and we've
This was great, guys.
Yeah.
I wish we had 2-3 hours on this. 'Cause this is
Yeah.
really interesting.
we wanted to give you guys these appreciation plaques for participating. And yeah, come on.
Just to let you know, you were given tickets. We have a raffle for you. Now, here are the ground rules.
Thank you.
If we call the number, no one shows up.
Yeah, thanks. Thanks.
We're gonna give them like 10 seconds to claim it, and then we're gonna draw another number.
And then and we also have a gift for I told you RSVP. On Monday we gave away the gift for the first person that RSVP.